Yes, thank you. Thank you all for having me. And I think, Victoria, you said skip my slide, my intro slide.
You can go ahead if you'd
Yeah, I
like.
think you
Okay.
could. Okay, yes.
Well, thank you all so much for having me. It's an honor to be here. I've done a couple of different things with Share and have nothing but great things to say about your guys' support group and organization. And thanks for sharing your stories too. Sounds like a lot of people are kind of familiar, or maybe have been through the process, or maybe unsure what testing they might have had. So definitely apologies if some of this may be repetitive, but or maybe it's just jogging your memories with some things, and hopefully you can learn some new things today from me too. So first, this Black in genetics. So this is actually not my picture that I made, but I just thought it was so great and so cool that they made the hair out of that's actually DNA strands. But it's essentially a support group for healthcare providers that are Black. So that's where I stole that image from, but had to give kudos where it was due. So our agenda today, I'll just introduce myself briefly. We'll really get into everything of the who, what, where, when, why, and how of genetic testing and genetic counseling. And then I know a big topic of today would be these disparities, in genetic testing itself. We'll talk about some research opportunities, and of course, there'll be time for questions at the end as well. So just briefly, why I'm qualified to give this talk or what I do. So I did my undergraduate degree at Northern Kentucky and Kentucky, and then I have my graduate degree in genetic counseling from Ohio State, and that's currently where I practice. So I specifically specialize in breast cancer. So I see a lot of patients that are newly diagnosed with breast cancer that may be coming to me that could help with their surgery decision. I do see a lot of people in our high risk clinic too. So a lot of the children of patients that have had breast cancer to know that their risk, or maybe they don't have cancer themselves, but just to know what their risk could be and could help with their screening recommendations. So I guess we don't necessarily need to do this since we went through. I was just going to pull who's met with a genetic counselor. So again, it sounds like a good chunk of us have some idea of genetic testing or have met with someone. So just getting right into the who, where, what, when, why, and how, not necessarily in this order. So who are genetic counselors? If you don't know, who we are. So different definitions for healthcare providers who help identify individuals at possible risk of a genetic condition. So we really specialize in a lot of different areas, but of course this talk will be on cancer, but there is prenatal, neuro, cardio, genetic counseling. So lots of different types of genetic counselors. We all essentially do the same thing where we collect your personal and family medical history if you know it. I just like to let people know too, even if you don't have that family history, whether you're estranged, adopted, we can still do genetic testing for you. Doesn't mean you can't get it, but sometimes that family history can help with our risk assessment. Who's more likely to have a genetic mutation versus those that are less likely? And of course, we facilitate that genetic testing. So we're very keen on facilitated decision making, and we'll go into that in a little bit more detail too, and informed consent. What I mean by that is, my appointments with patients at least are scheduled. We have an hour time length. So we have a lot more time than maybe some of your other appointments where you're meeting with, surgeons, medical oncologists that have a lot more patients, have a lot of more things to get through. So we really have an hour time to sit down and talk about everything, answer your questions. And we want to make sure that you know what you're testing for and want the testing. So we never force someone to do the testing. And then after we get your results, we're here for support as far as counseling, guidance, education, providing these resources for families to help understand their medical history. We also serve as educators for other healthcare professionals. So, I work closely with the surgeons at Ohio State, medical oncologists too. So we have that communication. And just so that you know what our credentials are. So most of us are board certified. So we take an exam to become genetic counselors. And most of us in a lot of the states, we have medical license in the state that we practice. So as far as, again, I said disparities is a big topic of today. So who are the chunk of the genetic counselors? So this number, it may seem kind of high. So we have approximately 7,000 genetic counselors in the United States. So that's compared to 700,000 nurses. So we really are a small population. This data is taken. So every year we send out a survey to all the genetic counselors. So this data that I gathered here is based on 2,400 respondents from 2024. So you can see as far as gender identity, mostly women. And you can see as far as race, mostly white women. So even within our own profession, we're underrepresented by males and we're underrepresented by every other minority group as far as, Asian, Black, Jewish, Hispanic. So even just within our own profession, we know that this has been an issue. A big issue with that is a lot of places we don't have scholarships to offer. So it's a very expensive career to go into if you don't have the money to get into it. So there's a lot of different things that we're trying to lower barriers to get into genetic counseling, to get more genetic counselors in different groups. And where are we? So I know we're kind of all over the United States. So I'm here in Ohio. This just shows you we are in every state, at least in the United States. There are genetic counselors in 28 total countries. So as far as the United States has the most, Canada and the UK, we do offer multiple delivery models. So even if you're in a state that doesn't have a lot of genetic counselors, COVID kind of, made telehealth. That was one good thing that came out of COVID. Of course, not a good thing overall, but really made telehealth widen, because where I was practicing, actually, we didn't offer telehealth. When COVID happened, we were forced to make those telehealth services. So over 75% of genetic counselors in that survey that we took responded that they do in-person group counseling as well as telehealth. So this just kind of shows you where the states that have the most in the blue here. So Texas is a big genetic counseling community, of course, in Ohio and California. Reasons for this in California is a lot of our genetic testing companies are actually located out in California, as well as it's kind of driven by where there are graduates. I don't know why that keeps going on itself. Apologies about that. As far as where our programs are. So Ohio actually has 4 genetic counseling programs, but some states may not have any, or they may only have 1 or 2. And then this just shows you where we are in the work setting. So most of you that met with a genetic counselor probably was in the hospital that you were getting your care, but we do work in government as far as policy making. Protections is a big thing that we're striving towards. We work in those laboratories, so there are people that are actually writing the reports, doing the actual testing. We work at universities like I do here at Ohio State, as well as biotech, pharmaceutical companies, and nonprofits as well. So what is genetic counseling exactly? So this is not necessarily a linear format, but this is just what could you really expect if you do go and meet with a genetic counselor? So really the first step is we do this sort of evaluation period where we're gathering that personal and family history of cancer. So those that have met with one, you may recall that it's where we're drawing those circles and squares. We're mapping out your family history. We typically draw the squares to identify as men. We'll draw circles for those that identify as women. And then we just, it helps us look at those patterns on who's had cancer in the family. Could we see it being passed along from generation to generation? And that's where we provide that risk assessment. By risk assessment, I mean, how likely is it that you could test positive for one of these genetic mutations? So we estimate in every family about 5 to 10% of cancers, we can find one of these genetic mutations. So a lot of people think that number is higher than it. I think that's what a lot of patients will tell me. They hear that number and they're like, really, that's it? And, I tell them 90 to 95% of the time, the results come back negative. We don't find that genetic mutation that explains why someone developed breast cancer. So there really is a lot that we still don't know. But also cancer, of course, is a multifactorial disease where it's a combination of genetics, environment, and lifestyle. So we can't really say one thing is the cause. We discuss, of course, the potential impact on personal screening management. And I'll give you all an example too with a specific BRCA mutation. And then, of course, that informed consent comes into play. So we make sure that you want the testing, you know what you're testing for. We'll go over the logistics. So a lot of questions that I get are, what's the cost of the testing? Will my insurance cover it? How long does it take to get those results? So that's all covered during your appointment as well. And then there's typically some sort of follow-up once we get those results. Different places do it differently. At least at Ohio State, typically it's a phone call, a MyChart message if people elect to get their results through MyChart. And we just go over the results together whenever those results come in. Other places, they may actually schedule a time where you'll go in and meet with your provider again and talk about your testing results. And I just like to preface too, just because you meet with a genetic counselor does not mean that you have to do the testing. So I get that question a lot too, but if you just want to collect that information, get some more info on it, you're welcome to just schedule an appointment. It doesn't bind you to getting the blood draw, doing the actual testing itself, and you can change your mind. So as far as breast cancer genes go, for the what of the genetic counseling is, so I mentioned, we say approximately 5 to 10% of breast cancers are hereditary. 50% of these mutations are in the BRCA1 and BRCA2 genes, or you may have heard them called BRCA1 and BRCA2. So what are those other 50% of mutations that are kind of less known? They're not as prominent in the media. So all of our genes are just a bunch of different letters and numbers. So kind of listed them in alphabetical order here, but there are 13 breast cancer genes that we now linked to. So I believe I heard one of the members here say that they had testing maybe in 2012 or 2013. So really, right, that's kind of right at the time where we do recommend doing updated testing. So if you had your testing, again, that 2012-13 is right at the cutoff. Before that time, we were only testing for BRCA1 and BRCA2, those two genes. So since then, if you were to get testing, like 2016 or later on, really, it's pretty much this panel testing as we know it today. So we're making sure that we test all of those 13 breast cancer genes. So if you were in that boat of, well, I was only tested for BRCA1 or BRCA2, or maybe you don't know how many genes you were tested for, that's something you could ask your provider. Do I need updated testing? Was I only tested for BRCA1 and BRCA2? And what else is out there? So this is just specific to breast cancer. So when I meet with patients, maybe you have a family history of colon cancer as well, or a family history of ovarian cancer. So really, we can do panels all the way up to 90 plus genes. They're all cancer specific genes, but it really is how much information you want. Do you want to check those colon cancer genes, those other ovarian cancer genes? Because potentially there could be something else in the family. It is rare to have more than one mutation, but we have, I've had a couple of families where we have found 3 different mutations. They could be coming from your mom's side of the family. They could be coming from your dad's side of the family. So all of these genes, they have different cancer risk, different lifetime percentages, and different screening recommendations. So that's my role. If you did test positive, I would walk you through the next steps, get you referred to the right people, do testing for family members if they were interested so that they can know their risk. So to give you an actual concrete example, so I just picked, again, BRCA2 because BRCA1 and 2 are kind of the more well-known in the media. BRCA1 and 2, they cause a condition that's called hereditary breast and ovarian cancer syndrome, or HBOC. So of course, we know breast cancer for females or individuals that are assigned female at birth, they have a 50 to 85% lifetime risk for breast cancer. I point out a lot too that men can develop breast cancer as well. It's just at a lot lower risk. So about 2 to 7% lifetime risk. The men do have breast tissue. They can get mammograms if there's enough breast tissue. The other big cancer risk is ovarian cancer, where we see a 10 to 30% lifetime risk. That's compared to the general population of 1%. Prostate cancer in men, again, I'll get asked, I'm worried about this for my daughters or for my granddaughters, but I just point out, it's important for your sons and your grandsons as well, even your brothers, uncles, because it can increase prostate cancer risk in men, as well as pancreatic cancer, which both men and women can develop, of course, as well as melanoma. So this just shows having one mutation in BRCA2 can increase all of these cancer risks. So it's more than just breast cancer risk that we can find out when we do this genetic testing. So then, of course, the question that I get asked is, well, if I get the testing and I test positive, what can I do about it? And of course, there are different screening recommendations. It depends on the gene. I just provided the screening recommendations for individuals that are BRCA1 and BRCA2 positive. And just to compare it here with what the general population screening we typically recommend. So people that, don't have a family history of breast cancer, typically we start mammograms at age 40. If you have a BRCA1 or a BRCA2 mutation, we typically recommend starting an MRI as early as age 25. The reason we do MRIs over mammograms or mammography is because women that are younger tend to have dense breast tissue. So you may be in the boat of someone may have told you, you have really dense breast tissue. So it can make things a little bit harder to see on your mammogram. So the MRI is a little bit more sensitive of a test where it can see more things. With that being said, it can see more things that aren't cancerous. So it can lead to more biopsies. So there, of course, is always a trade-off with some of these things. You'll notice too, so that we start mammograms at age 30. and again, can consider it for men at age 50. Other options, if we don't do that increased screening or surveillance, would be considering the risk reducing mastectomy, which would be removing the breast completely. We estimate that negates the risk between 90 to 95%. So we still can't say 100%, just because we can't get every possible cell. There can be residual chest wall that's left over. So that's why it's not 100%. There's something called chemo prevention. This is more for individuals that have not been diagnosed with breast cancer. So they can actually take some of those medications that maybe you all have taken after your diagnosis, like tamoxifen or raloxifene, that are hormone blockers. So people that don't have breast cancer can also take those preventatively to lower their breast cancer risk. We estimate that cuts it in half or by 50%. So I always tell people, when you get your results, you don't have to make this decision today. You can have time to think about it, but just know there are different options that you could pursue. And even within the same family, I've had sisters that both tested positive for, and they can do different things based on what's right for them. So you'll notice with the ovarian cancer risk, we don't have general population screening. So women aren't regularly screening for ovarian cancer. The reason for that is we don't have great screening tools in place. We do have a blood test that's called CA-125 screening, but we have a lot of false positives and we have a lot of false negatives with that test, meaning if that CA-125 level is high, indicating that you could have ovarian cancer, it doesn't always mean that you do have ovarian cancer, and vice versa. If it's lower, if it's within normal range, doesn't mean you don't have ovarian cancer. So there's really no general population screening. That is why really with a BRCA1 or a BRCA2 mutation, our only recommendation there is to remove the ovaries. So that's called a bilateral oophorectomy. And we typically say after childbearing years or between the ages of 35 to 45, because of course we still want individuals to have children if that's something that they want to do. So after childbearing or between the ages of 35 to 45. For prostate cancer screening, you'll notice, so this PSA screening, it's also a blood test that we recommend the general population, do annually. If someone has a BRCA1 or BRCA2 mutation, we start at 10 years earlier. So starting at age 40 instead of age 50. For pancreatic cancer screening, you'll notice again, no general population screening. It's kind of the same reasons for why we don't have ovarian cancer screening. Our screening just isn't great. It's not detecting it at the earliest stages where it's actually lowering the overall survival. But if there is a BRCA mutation and there is a family history present, we can do an MRI or an ultrasound guided endoscopy. So a little camera that goes down the throat, starting at age 50 for that screening. So again, this is specific to BRCA1 and 2. There can be some genes, for instance, there's a gene that's called CHEK2, which is breast and colon cancer. For that gene, we start colonoscopies 5 years earlier. So we start at age 40 instead of 45. So this screening all comes from, you may have seen at the bottom of my slides here, NCCN, which stands for the National Cancer Comprehensive Network. So it's an organization of 50 plus organizations that get together, they pool this data, and they come up with these screening recommendations. So that it's not from me or your specific provider, it is national guidelines, national criteria of all the data that we've collected. So one is genetic.
Yeah, no, we'll ask questions at the end. I see it, and I'll go back to your question, Dana, in a little bit. Thank you.
Sure. So when is genetic counseling indicated? So specifically when this group, you may not need me to tell you this, but Black women, they have a higher rate of triple negative breast cancer. They also have a higher rate of being diagnosed under the age of 50. So for that reason alone, again, this is the NCCN criteria of who should consider doing genetic testing. You'll notice one of those criteria is just being diagnosed at age 50 or younger, regardless of your type of breast cancer. Another is, regardless of age, just any triple negative breast cancer meets criteria or someone who should do it. And this is, again, who's more likely to test positive. It doesn't guarantee that you would have a genetic mutation, but these are the guidelines that we look for, who is at a higher risk of having one of these. So by that, you would think, well, Black women are diagnosed at younger ages and they have triple negative breast cancer. Shouldn't they they should be the ones that are getting the genetic testing the most. But as we'll go into the disparities, that's actually not what we're seeing. We're seeing the opposite, where more white women are getting the genetic testing. Other things to consider, if you're thinking, do I fit into this box or should I do genetic testing myself, regardless of age, again, if you've had more than one primary breast cancer diagnosis. And what we mean by primary, it's a little bit different than a recurrence, but that would mean you have a new breast cancer. Could be on the same breast, could be on the opposite breast as well, but it's a little bit different than a recurrence. And then some other things to look for if you have the lobular breast cancer type, and specifically if you have a family history of a diffuse gastric cancer, which is another word for stomach cancer. So that's linked to a specific gene that's called CDH1, where we see breast and gastric cancer together. So that's why that criteria is on there. Anytime there's male breast cancer in a family, and again, that's just because the male breast cancers are a lot rarer. So in the general population, it's about 0.1%. So compared to 13% of women. So a lot lower rates. Anytime there's Ashkenazi Jewish ancestry, the reason for that specific criteria is because Ashkenazi Jewish ancestry has a 1 in 40 chance to have a BRCA1 or a BRCA2 mutation. That's because there are 3 different what we call founder mutations within those 2 genes, where they just started off in Ashkenazi Jewish population. That was before people were migrating. So they stayed in one area, were repopulating. So that's why we have a 1 in 40 carrier rate in that population, compared to the general population has a 1 in 500 chance to have a BRCA mutation. Another big reason, or a lot of the patients that I see, is to aid in their adjuvant treatment decisions. So I know one participant said, I had this test to know if I should get chemo, which I believe that may have been, there's something called an oncotype. So they'll look at that to see how high your recurrence risk is, and that kind of guides chemo, but also with the genetic testing. So specifically with BRCA mutations, if you were to test positive, there's something that's called a PARP inhibitor that we know works better for individuals that have breast cancer and have a BRCA mutation. So that's one way that it could change what your treatment plan is. It also could influence what surgery plan that you decide to do. So I'll have a lot of people that maybe are deciding between a lumpectomy versus a mastectomy. So lumpectomy, just removing the cancer, the site, versus a mastectomy, the full breast or the whole breast. And if there is a genetic mutation where we know that person could be at a higher risk for a second breast cancer, a new primary breast cancer, they may elect to do a full mastectomy because they know they're at a higher risk for recurrence. They may also elect to remove the opposite breast, or the breast that doesn't have cancer, again, and that being a preventative measure. So that's all the specific for personal history of breast cancer. Again, even if you don't fit into one of these boxes, you can always reach out to your provider and see if genetic testing would be right for you. I test people that don't necessarily fit our criteria because, again, it doesn't mean you couldn't have a mutation if you don't fit into one of these boxes. Other criteria or other things that you should look for in your family history would be if you have one or more close blood relative. So when we say close blood relative, we typically focus on those 1st and 2nd degree relatives. So your siblings, your kids, your parents, your aunts and uncles, but we do go out to those 3rd degree relatives as well. So we do consider cousins or your great aunts and uncles. So things to look for, kind of what we touched on before, is the younger ages of diagnosis, as well as male breast cancer, if there's ovarian, pancreatic, or metastatic prostate cancer in your family. If you don't fall into any of those boxes with the younger ages, regardless of age, anytime there's 3 or more diagnoses of breast and prostate cancer together on the same side of the family, we recommend considering the testing. So that would be including yourself. So if you've had breast cancer, that counts as 1. If you have 2 other people on the same side of the family, meaning on your mom's side of the family or on your dad's side of the family, you would meet our criteria. So we don't look at, say you have 1 person on mom and 1 person on dad's side plus you, that wouldn't meet the criteria because we look at mom and dad's side of the family separately. So I'll get this question a lot as well. Why should I consider the testing, or why shouldn't I consider the testing? What are the pros and cons of this testing? So I kind of tried to pair the benefit. It's a double-edged sword is what I hear a lot of patients say. So I tried to pair them with each other. So one of the benefits that I mentioned is to aid in that personalized management, such as your surgery decision or treatment. So with the PARP inhibitors, on the flip side of that, it doesn't detect all mutations. We do not know all genes associated with breast cancer. So if you recall from what I said before 2012, we were only testing for BRCA1 and 2. Well, in 12 years, we added 11 genes that we've now linked to breast cancer definitively. There are still a lot of other investigational genes that we're looking at. It just takes time to collect that data, as well as we need people to do the testing so that we can collect that data. Another benefit would be potentially to find an explanation or the why of why you develop breast cancer. So, I personally have had a patient that, I called them with their positive results, which, is always hard as a provider too, to let someone know this, but some people are relieved when they hear that they're positive, or, because they're like, well, I don't know what caused it. I'm kind of happy that I found this explanation, or I know it wasn't anything I did or didn't do. So to just have that explanation sometimes can provide peace to some people. But on the other side of that, most of these genes, as I mentioned, they can identify if you could be at risk for an additional cancer. So typically, there's another cancer that's on the lookout for us. Doesn't guarantee someone would develop a second cancer, but that's why there's those screening recommendations in place. Another benefit to think about, or something that I hear a lot of my patients say, is just knowledge for their family members. So I'll have patients that say, it's not going to change my surgery or what I decide to do. I just want to know for my kids if they could be at that increased risk. So, and that's a valid reason to do the testing as well. On the flip side of that, the risk would be there, of course, can be the psychological or economic harms or guilt if passing it on to your children. Because again, it's not anything someone did or didn't do. These are just things that we were born with. It was an error that occurred in utero, and it does have that 50-50 chance to get passed on to children. Another benefit would be, of course, that implementation of early detection, preventative strategies, and family planning. And I bring up family planning too, because there is the option. So say someone tests positive, they do want to go on to have a child, but they don't want to pass along the mutation. There is IVF with pre-implantation genetic testing. So in vitro fertilization, where they can actually test the embryos, and then they would insert the embryos that don't have the genetic mutation. So that's one benefit of potentially doing the testing and preventing it from being passed on to children. Of course, that can be expensive. So on the flip side of that, kind of the limitation or the risk could be, even if someone tests positive for one of these genetic mutations, I kind of hate this saying, but it is true. We cannot predict if, where, or when cancer could occur. So all of those percentages that I quoted you before, again, those are just percentages. It's not a guarantee that someone with a mutation does go on to develop cancer, or they couldn't develop a second or a third cancer. We just don't know. A benefit would be it could relieve this anxiety if you do test negative, to know that you can't pass something on. The flip side of that, of course, is it could provide this false sense of reassurance, because I'll have people, that come in for the cascade testing or familial testing, they're at that 50-50 chance, say, to have a BRCA mutation because there's one in their family. Even if someone tests negative for the familial mutation, they're still at general population risk for cancer. So we'd still quote them that 12 to 13% risk to develop breast cancer. So it's just important. I try to reiterate that with negative genetic testing. We still want you to be on top of your screening, of course. Another benefit would be there's lots of research and clinical trials to improve these disparities, which we're going to touch on in a couple of slides too. The risk with that is, of course, with some of these clinical trials, we don't know if you might get a placebo that's not doing anything for your risk. There can be side effects, and these interventions can be unproven, but we need to test them in some capacity, for future generations to see if these things can actually lower cancer risk, prevent cancer from occurring. So now, leave you with this quote here. I found this quote from the American Cancer Society. So one of the scientific directors, to bridge us into our topic as far as disparities go. So she quoted, "We have been reporting the same disparity year after year for a decade. The difference in death rates are not explained by Black women having more aggressive cancers. It is time for health systems to take a hard look at how they are caring differently for Black women." And I want to acknowledge again the member that you all have lost. I'm very sorry for all of your guys' loss. But it is true that we see Black women that die from breast cancer at a significantly higher rate than white populations. So I thought this was a really powerful quote that I just wanted to put out there, because again, a lot of the data is saying, well, women have higher rates of triple negative breast cancer, so that's why they're dying at higher rates. So we can dig into that, of course, and let me get a quick drink of water here.
Thank you, Chrissy. Is that it? I want to make sure. Were you getting a gulp and then you're going to continue? Or
Oh, yeah. I was just taking a little drink. So
yes, no, thank you. Thank you so much. You definitely deserve a little water break. Thank you so
yes.
much. It was very informative.
Oh, I'm still going. I still have some slides. Sorry.
Sure, absolutely. Show us.
So as far as the disparities in breast cancer go, so what I just said with the Black women, they have a 4% lower incidence of breast cancer overall. So they're actually, if you compare in this chart here, I don't know if you can see where'd my pointer go? You can see, can you see my mouse?
I'm not seeing the screen. Are others seeing your screen? Are other ladies seeing the screen?
Yes, I can see it.
Okay. So if you can see, this just shows the incidence. So this light pink box for white women, and this is per 100,000. So this isn't 133 people. This is 133,000 white women are diagnosed versus 127,000. So just overall, the incidence of breast cancer is lower for Black women, but 40% higher breast cancer death rate for all subtypes, regardless if it's triple negative, if it's DCIS, IDC. So that is just a quote that I don't want to quote, and I hate quoting. But you can see the dark pink, again, shouldn't be like that, but this dark pink box is higher for Black women than it is for white women. So what's causing this? And of course, I can't say one thing is the driving force. It's a multitude of factors in there. And this is actually, there's research studies to prove this. So this isn't me just saying, well, these are the things that I think it might be. There's actually evidence and data to support this. So one is, of course, that systemic racism can lead to a higher risk of lower socioeconomic status. That's lowering the access to care, people that are in more rural communities, later detection and treatment. So get into a lot of this on the second slide too. But as far as the later detection and treatment, some of these studies that have looked at Black women's attitudes towards healthcare providers, and there's just a lot of mistrust. And that goes back again to our history that I'll go over in on the next slide as well. So that later detection, they just don't have as much access to care, maybe because they don't have health insurance. So you'll notice I put that in bold here. So that is really a big driving force is health insurance. So people that are uninsured they're not getting their screening. They're getting detected at later ages, or maybe they don't go through treatment just because they don't trust their healthcare provider. Mentioned this a couple of times, but Black women are twice as likely to develop triple negative breast cancer. So of course, get back to that quote, can that contribute to why there's a higher mortality rate? Of course, but again, is it the only thing that's leading to that mortality rate? Absolutely not. So, and the kind of a reason for that with the mistrust is because they found that Black women are less likely to complete their chemo. So whether that's they just can't tolerate it well, or just maybe don't have the resources, they don't have the transportation, the health insurance, multitude of reasons. Another reason that could go into it is just there is the higher prevalence of comorbidities. So obesity, diabetes, and heart disease. So there are a lot more complications when going through that treatment. So these other comorbidities can relate to the mortality rate. Underrepresentation in clinical trials. So, we need more Black women to participate in some of these clinical trials because your genetics could be different. We need to learn more about your unique makeup in order to come up with treatments that are better for these individuals. So it's hard to lump everything into one slide, but these are kind of the main points, when you're looking at the research of trying to explain the why. So specifically in genetic testing, I don't want to put anyone on the spot. I was going to put the name here, but does anyone happen to know who this woman is? I'll give a second. Okay. So
Yes, we all know her.
I'm sorry.
Henrietta Lacks.
Yes, exactly. So, if we think back to disparities in genetic testing, I won't bore you with all of the history, but if you find it interesting or don't know who she is, there's a book called The Immortal Life of Henrietta Lacks. So it's very empowering to read, but in a nutshell, what happened was Henrietta, she had cervical cancer, and they took a sample of her or biopsy without her consent, and they labeled them HeLa cells. So if you hear HeLa cells, it stands for the first two letters of her first name, so HE, and the first two letters of her last name, So LA. So that's how they got HeLa cells. And they found that hers were the first cells that survived in the lab. They could clone them. And pretty much anything medical that you can think of, HeLa cells have contributed to that progression. So polio, even the COVID-19 vaccine recently, her cells have been used in the lab to help study these things. But they took her sample without her consent. Her family didn't know about it. I believe it was 15 years, and they didn't know until these people were reaching out to them to try to get their blood samples, and they didn't know why they were getting reached out. So it's a long way to say there was no consent in getting her sample. Her family has not been given any of the money. You know, all these pharmaceutical companies are getting money from them, and her family has gotten nothing. So it's an ongoing thing if you're interested in that history. So that was just the first thing that I could recall as far as disparities in not genetic testing per se, but just anything medical. So as far as other things in genetic testing to think about, so as I mentioned, we do have specific guidelines that we say who is more likely. So those guidelines can be restrictive as far as who should we recommend testing. But again, there should be a higher proportion of Black women given the triple negative and being diagnosed at earlier ages. But some of these, I just put the authors. I have a reference slide in case you all are interested in getting more in depth on the research here. But one study actually found there's no difference in positive rates between those meeting 2017's NCCN criteria versus those that didn't meet criteria. So what that means is there was no difference in those, that list of guidelines that I showed you all before, whether they met criteria or not. There was the same positive rate or the same number of people that were testing positive. So, kind of how are we moving forward? So in 2019, the American Society of Breast Surgeons released a statement that recommends genetic testing to all patients newly diagnosed or with that personal history of breast cancer. So just saying anyone with breast cancer should consider doing the genetic testing. That is not how us as genetic counselors currently practice, but that's definitely a step towards other, organizations coming out with this statement. And really the limitation to it, why we're not just doing all people, is partly for resources. Again, we only have 7,000 genetic counselors. There's over 310,000 newly diagnosed individuals with breast cancer. So we just don't have the number of genetic counselors to support that. But, if we were doing that, though, that takes away the guidelines. It takes away providers having to refer to us to get the genetic testing. So I really am an advocate for everyone considering doing the genetic testing, but we definitely need to make a new model. We need to get healthcare providers helping ordering the testing because genetic counselors we just don't have the bandwidth for the amount of patients that get diagnosed. Another thing to consider would be with this study, Korean et al. In 2018, they found that there was a significantly lower provider referral rates for Black women. So 75% of Black women were referred versus 93% of white women. But after these patients were referred, there was no difference in the uptake of who did do the genetic testing. So that's significant enough to say, again, if we took away those guidelines and we just said, test everyone, that would take away that issue of having to refer and potential discrimination based on ancestry. A third thing would be the study from 2019. Black women have a significantly higher variant of uncertain significance rate. So if you're not familiar with this terminology, when we do the genetic testing, there are actually 3 different results that we can get. So a positive result would mean we found a mutation. Negative result, no mutations identified. So those are a little bit more straightforward, but this gray area that's called a variant of uncertain significance just means that we found a change in a gene, but we don't have all the information yet to say, yes, this is cancer causing, or no, this is just something that's benign. It's a non-cancer causing change, something that just makes this individual unique. So if you compare Black women have a 44% VUS rate or uncertain result compared to 24% of white women. Why is that? So there's a lot more uncertainty in Black women. We're getting a lot more uncertain results with the genetic testing simply because we don't have the data. Less Black women are going through with the genetic testing. So we don't have, the human genome mapping that was completed. It looked at a lot of ancestries, but we need more people of Black ancestry in order to clarify these uncertain results. Are these just common changes in the Black population that we haven't seen before? So we need more data so that we can reclassify these variants and, have a little bit more certainty. So this just shows that this Nomad, it's where we put all of our variants into one database to do this research. So it has 142,000 unrelated individuals. We have consisting of 585 European ancestry compared to only 8% of Black individuals. So again, most of our data that we're looking at is of those individuals with European ancestry. Other things to think about would be the cost of the genetic testing. So in this instance, I think we've really progressed. But how I mentioned, people that don't have health insurance, that's a limitation to getting their care. It's a limitation to pursuing the genetic testing. A lot of our genetic testing companies, they do offer financial assistance programs. So we never want cost to be the reason someone doesn't get referred to us or declines the genetic testing. We can run it through financial assistance for those that are uninsured, or for people that just don't have great health insurance too. A lot of the labs, they do offer self-pay prices of $250. Now I know $250 can still be, a burden or still be an expensive amount. So of course there are those financial programs that are in place to potentially help with that. It's all based on self-reported, so you just fill out this form. It's based on the annual gross income number of individuals in your household, and we can always run it through, get a cost estimate before doing the actual testing. Kind of mentioned this on the other slide as far as the access to the genetic counselors. If you're not getting referred or don't even know to ask, your provider, should I get genetic counseling? Of course, that's a limitation. And I already kind of mentioned this, the number of genetic counselors. So there's 310,000 new breast cancers diagnosed or estimated for the year of 2024 compared to 7,000 genetic counselors who are not just seeing cancer, just breast cancer. So we're seeing all different types of cancer as well as other indications. So just a brief overview of, how can we help with this disparity or close this gap, or what are we doing? So the American Cancer Society, they actually have this cancer prevention study. So it's a 40-year study that started in 2013 of 300,000 racially and ethnically diverse U.S. and Puerto Rico cohort. So they collected blood samples as well as other biosamples and surveys where they're looking at who's been diagnosed with cancer, what are their lifestyle factors, what do they identify as their ancestry goes. So it takes time to collect all of this data, but I'm really excited to see the results of this. So they send a survey, I believe it's like every 7 years to keep track of all of these individuals. And of course, there's going to be dropout, but I provided the links too in case you wanted to investigate that study a little bit more. This MAGIC study, so this is to bridge the gap between the access to genetic counselors and the number of genetic counselors that are needed to support all newly diagnosed individuals. So this study, it's looking at what we call universal genetic testing. So universal genetic testing for all, where they did have physicians order the testing. So one good thing about that is it decreases the amount of appointments that you need. I know, as you all know, going through your breast cancer journey, you have a lot of appointments, and you probably hear, oh, I have to make another appointment with a genetic counselor. So that would kind of decrease, you could just meet with your surgeon, your medical oncologist, whoever it may be. They could order the genetic testing instead of you having to meet with another person. Of course, that requires education on the physician's side of things. I went to school to do this, to do the genetic counseling. So kind of the downside of that, you don't have that hour appointment to get all of your questions answered. Maybe you don't get as much informed consent of what the testing is. And then what they found too, but they found there was no emotional burden with individuals that did pursue the testing with their physician, but it did result in a 44-day turnaround time. So it took over a month to get the results out without a genetic counselor. Compared to a meeting with a genetic counselor, there are stat panels that we can run for individuals that are newly diagnosed where we can get those results in 7 to 10 days. So again, there's pros and cons to everything, but there has to be this new model to get all these individuals testing if they want it. Just to highlight a trial, I will say I'm biased. I am helping on this trial, so it is a little bit of a self-plug here, but it's a universal or national multiple countries that have this specific trial. It's specifically for unaffected women with a BRCA1 mutation. So I know everyone in this group has had breast cancer, but if you did testing, if you have a daughter, a sister, an unaffected relative, we're testing this drug. It's not a new drug called denosumab. So to see, can it actually lower the breast cancer occurrence in BRCA1 positive individuals? So again, potentially we could have this new drug that could be offered that wasn't offered before for these BRCA1 individuals, but we need participants of all different ancestries, of course, to enroll. And then I'll leave you with, I know we're running short on time, so how to find a genetic counselor. So ask your doctor. If you're not comfortable in that sense, you can go to findageneticcounselor.nsgc.org. You can type in your zip code and it'll pull up a genetic counselor that's in your area. This genomemedical.com, it's an online resource, so you could do telehealth. So it's not through like a specific like Ohio State University or institution. It's just its own telehealth resource for genetic testing. I think that's everything. So sorry, I went a little over on time, but I'm happy to stay for questions if anyone has them. But I know your guys' time is important as well.
Oh,
if we
thank
need to
you
hop
so
on.
much. It's perfectly fine. Thank you so much, Chrissy, for sharing your expertise and insights with all of us today. So it was very invaluable, and we're very appreciative of you sharing it. I know that I did see I have my own question, but I wanted to, I know Dana